Hi, for those that haven't met me personally yet, I'm Dr. Hargroder, and I want to say, first of all, congratulations. I hope you're as excited as I am for what's about to happen here in the next few days or so. The purpose of this video is just to get you ready for your upcoming surgery. This is a video that ought to be watched by you, as well as your support person and any other family members that could add as supplemental support people, and certainly for those that are going to be at the hospital with you. This is a very practical video just to help get you through the first 24, 48 hours after the surgery. So let's talk about the day before surgery. You're going to come into my office. Tanya's going to visit with you. Sherry's going to visit with you. They'll exchange a little bit of paperwork. On that day, preferably first thing that morning when you get up, you ought to take a dose of milk of magnesia. Now that's just a laxative, kind of cleans out your colon. And the purpose of that is to make my job easier. Anything that makes my job easier is better for you, right? So if you can get the colon evacuated to where things are flattened out and I have a little bit more room to operate, that's very helpful. So make sure you get that dose of milk magnesia in. If you don't have great results, don't worry about it. I've never canceled a case because the colon was too full, but it's just one of those steps we take to make the operation as safe and effective as it can be. Now, while you're in the office, you're going to get a bottle of some body wash. You'll be instructed to use that the night before surgery and the morning of surgery, and that's just to help reduce the risk of any kind of skin infections or wound infections. Now, even though you're taking your dose of milk of magnesia that morning, the night before surgery, if you want to go out to a restaurant and have a nice meal, you're certainly welcome to do that. You can eat whatever you want, no restrictions on that. But after midnight, nothing to eat or drink. And that includes chewing gum. I've actually had a case that was canceled by anesthesia because chewing gum stimulates acid secretions in the stomach and increases your risk of aspirating when they put you to sleep. So nothing to eat or drink after midnight. The only exception is if there are some medications that you need to take the morning of surgery, you do that with a small sip of water. Now, the day of surgery is something that we've tried to streamline and make as simple as we can. And one of the nice things about the hospital that I operate in, McCune Brooks Hospital, is that it's a relatively small community hospital. So from the time you get out of your car and walk to the front door, it's about 15 feet to the registration desk. It's another 10 feet to the waiting area. And your family can stay with you the whole time you're in that pre-op area. In pre-op, they'll start an IV, they'll get you changed and get you ready. They'll have you sign a couple more papers, and then we're off to the operating room. The surgery itself is going to take anywhere from 30 minutes to an hour and a half. Our average time is about 45 minutes or so. And what I have done, because I know what it's like to be a family member sitting out in the waiting room worried about your loved one having surgery, I have a sort of self-imposed rule that if the surgery takes longer than an hour, I'm going to be sending word out through a nurse or somebody to talk to your family to let them know a progress report of how things are going. More than likely, it'll be me coming out to let your family know that the surgery is finished, but if the surgery should take longer than an hour, someone will be coming out to give a progress report. So the point being too, if someone comes out, calls out your name to your family, it doesn't mean there's a problem. We're just giving you a progress report. Now, from the operating room, you're going to go to the recovery room. And in the recovery room, I want to warn you that you are going to experience some pain and maybe some nausea. That's just common. You've just had surgery. Everybody experiences some pain and nausea. Now, the good news is you've got a nurse sitting there 2 feet away from you, and every 5 minutes she's asking you, or he's asking you, what your pain level is, rate your pain. And they've got a whole list of drugs that they're able to give you, whether it's morphine or Dilaudid or fentanyl, to relieve your pain, as well as drugs to help with your nausea. You'll be in the recovery room for about an hour to an hour and a half. That's a good time for your family to maybe go and grab a bite because they're not going to be able to be with you while you're in the recovery room. And then once you leave the recovery room, you'll go to the floor where the nurses will take care of you. Now, one of the reasons I mention you're going to have pain in the recovery room is because if you've done your homework, you also know that pain is one of the main symptoms of someone who's had a leak. And we know that a leak is a very bad complication. It's a very dangerous complication and one we work very hard to avoid. And so I don't want you to wake up in the recovery room and the first thought going through your mind is, oh my God, I must have a leak because I'm hurting. I want to reassure you that the pain that you're having in the recovery room is normal and everybody has it. Now, once you get to the floor, there are 3 things the nurses are going to be looking for: pain, fever, and a rapid heart rate, usually over about 120. And if you have those 3 things, pain, fever, and a rapid heart rate, those are signs of a leak, and we're going back to the operating room. Whether it's at 2 o'clock in the afternoon or 2 o'clock in the morning, we're going back to the operating room. I would rather be wrong, take you to the operating room and not find a leak, than to ignore those symptoms, hoping that they'll go away, and then too much time has gone by and we've taken a problem that can be easily fixed and turned it into one that can be quite difficult to fix. Now, because a leak is such a terrible complication, we go to great measures to try and avoid a leak. And so one of the things that I do at the very end of the case is I'm going to fill your belly full of saline solution. And just like checking a flat tire, you dunk it under water and you fill it with air and you watch for air bubbles. Well, your new little stomach that we've created has a staple line, and we're going to have a tube that goes through your mouth into your little stomach. And you'll be asleep, so you won't feel any of this. But with your stomach underwater, we're going to blow some air into your stomach and look for bubbles. If there's bubbles, we throw a couple extra stitches to reinforce things. And since doing that, we've cut our leak rate down from 1 leak a year all the way down to we've had 1 leak in the last 3.5 years. So it's a great way to reduce that risk. Now, the reason I'm telling you about it, because I could do this and you'd never even know about it, but the reason I'm telling you about it is one of the things that we want to make sure you're aware of is that it's a lot easier to put 3 liters of fluid into your belly than it is to try and suction it out. And while we do our best to try and get as much of that fluid out as we can, there is some fluid that we're just not going to be able to get out. And you might find yourself getting up to go for a walk and blood-tinged fluid comes pouring out of your wounds, kind of like those cartoon characters that get shot by a shotgun or whatever, and they drink a glass of water and the water comes pouring out of their belly from the bullet holes. You might find that you have this blood-tinged fluid coming out of your incisions. And let me tell you, it'll catch your attention and you'll think something is horribly wrong. It could be quite scary, except that I'm here to reassure you, it's nothing to worry about. It's just that irrigation fluid coming out, and more than likely it's not going to happen. But if you're one of those few lucky ones that gets to experience this, and of course I say that facetiously, you'll be thankful that I'm giving you this little heads up here. All you got to do is call the nurse, ask her to come and help you, and they'll get you cleaned up and put some fresh bandages on, and it'll stop on its own. Nothing to worry about. So, again, pain, fever, rapid heart rate, we're going to go back to the operating room. Now, there is one thing I want to say about that from a financial liability issue, and that is, if we have to go back to the operating room, you will not get an additional charge from me. You will not get an additional charge from the hospital as long as I can still get you out of the hospital within about 2 or 3 days, which we usually can. But you will probably get a bill from the anesthesia group. And I'm sorry, but it's just the way that it is. They have to send their personnel to take you and put you back to sleep the second time. and you will receive a bill from them, which is something you would be expected to pay, and it could range anywhere from $500 to $1,500 depending on what time of day or night it is, how long we're in the operating room. Now, that also brings to mind a point that I want to make sure you're aware of as well, and that has to do with a problem that we have had with the billing office from the hospital, and it is this, and we've been fighting with this for over 2 years now, can't seem to get it fixed, and so I'm left with simply warning you about it. And that is, if you get a bill from the hospital, I'm here to assure you, you weren't supposed to. But I also encourage you, don't ignore the bill, but also don't get mad about it. Just call Tanya or Sherry and say, hey, I got this bill for $20,000, $30,000 from the hospital. What am I supposed to do with it? They'll make a couple of phone calls and we'll help you get it taken care of so that bill goes away. So if you have a routine, uncomplicated MGB and you get some big bill from the hospital, that's a bill you weren't supposed to get, let us know about it. We'll help it to go away. But don't ignore it either. Now, next what I'd like to do, and hopefully you've already seen this video, but I think it's just a good idea in the week or so before surgery to review it one more time, is I want to show you the video, this animated video of the operation itself. Now, before we actually look at it, one of the things about the video is it shows how the stomach is divided and how we create the anastomosis, but it all sort of magically appears. It doesn't show you the instrumentation that goes into creating this transition. And so the first thing I want to do is just show you this photo of an instrument called the endo-GIA. And this instrument is the one that really does most of the work in the operation. This is an instrument that has really revolutionized laparoscopic surgery. We use this for everything from appendectomies to hysterectomies to lung resections, colon resections, and of course, for weight loss surgery as well. And if you look closely at the tip of it, it's essentially a stapling device and a cutting device. So there's 3 rows of staples on each side and then a scalpel blade down the middle, so that when you fire the instrument, when you squeeze the handle and fire the instrument, it's cutting and sealing in a watertight seal with the 3 rows of staples on each side with each pass. So I just wanted you to get a feel for this instrument and how it creates this staple line. So now we're going to watch the video, and once the video is done, then I'll be back and we'll kind of wrap things up.
This short video will explain the normal process of digestion, the mini gastric bypass procedure, and how weight loss will occur upon completion of the surgery. In the normal digestive process, food travels from your mouth, down your esophagus, and into your stomach. Currently, your stomach can hold about 40 ounces of food. Once in your stomach, the food combines with digestive juices containing acids and enzymes that help break it down into smaller particles. Once broken down, the small particles are slowly released into the first part of your small intestine, the duodenum. Most of the calories and nutrients from the broken down food are absorbed in the duodenum and the jejunum, which is the second part of the small intestine. Food particles not absorbed by the small intestine leave the body in the form of waste. The steps in the mini gastric bypass involve placing 5 trocars in your abdomen, creating a narrow stomach pouch with an endoscopic stapler, measuring to a bypass point on the small intestine, creating an anastomosis between this bypass point and the small stomach pouch, and finally, reinforcing the anastomosis with sutures. The mini gastric bypass surgery begins with the surgeon inserting 5 trocars into your abdomen. A trocar is a tool that has a hollow sleeve and allows your surgeon to pass a laparoscopic video camera and other endoscopic tools into your abdomen. This allows your surgeon to perform the operation from outside your body. Your surgeon will use an endoscopic stapler to divide your stomach into 2 parts. the smaller part that connects to the esophagus, is reshaped into a long, narrow tube and will serve as your new mini stomach. It will only hold 4 to 6 ounces of food. The larger portion of your old stomach will remain alive and inside your body. It will still produce digestive juices to aid in digestion, but it will no longer come into contact with food. Next, your surgeon will measure the length of your small intestine that will be bypassed. This bypass section will include all of the duodenum and part of the jejunum and is usually between 5 to 7 feet from where the small intestine connects to the larger portion of your old stomach. The length of the bypass is determined by your specific physical condition and lifestyle situations. Your surgeon will then connect the end of your new mini stomach pouch to the bypass point of the small intestine using the endoscopic stapler. This connection point is called an anastomosis. Once this connection is completed, your surgeon will reinforce the outer circumference of the anastomosis with sutures. Finally, your surgeon will close the trocar holes with sutures. Weight loss after surgery will occur for multiple reasons. First, your new mini stomach will hold much less food, causing you to feel full more quickly. Therefore, you will eat smaller amounts. Secondly, once food leaves your mini stomach, it will bypass your duodenum and part of your jejunum. This means less calories will be absorbed by the body. However, digestive juices from the large portion of the old stomach and enzymes from the gallbladder will still travel through the duodenum and will meet up with the food at the bypass point. These acids and enzymes will aid in digestion as food travels through the remainder of the small intestine. Finally, certain hormones that regulate your appetite will be affected after surgery. Therefore, you will eat less, not only because your stomach is physically smaller, but also because this change in hormone levels will suppress your appetite.
And now, before we wrap things up, I want to mention one more thing, and that has to do with relationships. Relationships, fortunately, are normally enhanced after this surgery. It's wonderful to hear the stories of couples who are out enjoying life more than they ever did. But I also have to warn you that I do know of stories of patients of mine, including one that is hit very close to home because it was one of my best friends growing up through elementary and high school. We remain great friends today, and I did his surgery several years ago. And about a year after his surgery, he ended up getting a divorce. And he, like others, told me they feel like the MGB has contributed to that. And so I feel like being forewarned is forearmed. And so if you have a loved one, if you have a spouse, a partner, a boyfriend, girlfriend, before the surgery, I want y'all to talk about this. I want you to look each other in the eyes, hold each other's hands, and say, we're not going to let anything like this happen to us. Now, what exactly am I talking about? Well, imagine, you're the female, you've lost 100 and 150 pounds, and now all of a sudden, instead of sitting at home exhausted, you're feeling full of energy and you're ready to go out with friends and maybe go to dinner or maybe go, doing some event to the movies, or maybe you've picked up an athletic hobby. Your husband's at home wondering, well, why isn't she home taking care of me? That's where she usually is. And so husbands can get a little insecure about that. Or maybe you're walking into a restaurant and, men start noticing you more than they did 150 pounds ago. And husbands can get a little jealous and a little insecure. They may even think you're enjoying it a little bit too much. And so these are just things to be aware of. If you've got girlfriends, women, if you've got girlfriends, especially the younger women, the 20, 30-year-olds, and you've got some girlfriends and y'all have been hanging forever. And now all of a sudden you lose 150 pounds and you've gone from being the heaviest in the group to the thinnest in the group. I'll tell you, you're going to find out who your real friends are. So just be aware of that people can get jealous, and it can affect those relationships as well. The men kind of have the same problem. Men, after losing all that weight, all of a sudden now they're ready to go out hunting and fishing or golfing or just doing things that they normally would just be sitting at home with their wife because they were too exhausted to do anything else. And wives can get a little bit insecure about that. To compound that problem, now you've also got a lot of hormonal changes. The men will have a little bit more of a short temper and a little bit more aggressiveness to them as their testosterone levels go up. The women, with their estrogen levels being depleted as the fat cells melt away, might find themselves with either PMS type symptoms of real irritation and agitation, or maybe even like postpartum depression, where you're just feeling sad and tearful for no real good reason. And so these are all things I want you to be aware of it. I don't want to spend too much time on this, but I just feel like it's something worth mentioning. Now, one final thing that I want to do is I want to try and guess how much you're going to weigh in 2 years. So if you've got a smartphone or a pencil and a paper, we're going to do a little math problem right now. And we're going to try and figure out how much are you going to weigh in 2 years. This is not a promise or a guarantee. It's just sort of a prediction. That's a fun little exercise that we like to do because it's kind of amazing how many patients come and tell me, indeed, that they really were, right on, spot on with the mark. Now, how are we going to do this? Well, what we know from our own statistics is that our average patient loses about 71% of their excess weight at 2 years. So what does that mean exactly? You lose 71% of your excess weight. Well, imagine if you weigh 200 pounds, but you're supposed to weigh 100 pounds. Well, then you're 100 pounds overweight. We would expect that person to lose about 71 pounds, and therefore they would weigh 129 pounds at the end of 2 years. Okay, so you see how the math works. Well, we're going to apply that to your specific situation. Now, if we were to assume that a body mass index of 21 is the weight you're supposed to be at, okay? Body mass index of 21 is the weight you're supposed to be at. Well, we figure that out by looking at this chart here. And you take your height, which is over in the right-hand column in inches, and we take your weight that goes across the scale here, and look at the third column. And the third column shows a body mass index of 21, so follow that column down, make your height and your weight match, and you'll find what weight you're supposed to be to have a BMI of 21. If you're 5'7", to have a BMI of 21, looking at this chart, you would need to weigh 134. So write down what your weight needs to be to have a BMI of 21. That's the first number I want you to write down. Now, you also know what you weigh today, right? Well, take what you weigh today minus what your weight would be if you had a BMI of 21. And that's going to tell us how much overweight you are, okay? Your weight today minus that weight of a BMI of 21, whatever that weight is. Now, for the men, I know you look at the chart and it'll say if you're 6 feet, you're supposed to weigh 155, and most men that are 6 feet tall don't want to weigh 155. Forget about that. For the sake of calculations, take your weight today minus the weight you're supposed to be to have a BMI of 21. That tells us how much overweight you are. Now, what we know is that you're expected to lose about 71% of your excess weight, right? Well, we're going to use the number 70% just to make the math a little bit easier. So take that number that you just calculated, your today's weight minus the weight for a BMI of 21. Take the result of that and multiply it by 0.7. And if you multiply that by 0.7, that represents the 70% excess weight loss. That's going to tell us how much weight we expect you to lose in the next 2 years. So that answer that you just get you just got is the amount of weight you're expected to lose over the next 2 years. So if you want to know how much you're expected to weigh 2 years from now, take your weight today minus the amount of weight you're expected to lose, and the answer you get is going to be what you're going to weigh 2 years from now. Hopefully you're happy with that number. I want you to remember this number because we're going to be discussing that when you come in to see me the day before surgery. Now, if you're not satisfied with that number, there are two things that I have to say. And most people that aren't satisfied with it because it's more than they hoped it would be. But remember two things. Number one, these are just statistics. We have some patients that will lose 100% of their excess body weight and get all the way down to a BMI of 21. But we also have some patients that only lose 40 or 50% of their excess weight. Now, if you want to try and maximize your chances of being one of those that loses more rather than less, then I'll have a couple of pieces of advice for you here in just a minute. But it's basically, remember that this is just a tool to help you get where you want to be. If you take it that way with that approach, get in some good healthy diet, exercise, and stay in touch with us, you're much more likely to have positive results and extra weight loss than the person who takes the attitude, well, I had the surgery, now I'm going to go home, kick up my feet, watch TV, and start eating, chocolates and junk food. You're more likely to be one of those that loses less weight. Just seems like it's common sense, right? The other thing I want to remind you of is my job. I don't consider my job to make you skinny. My goal is not to make you thin. My goal is to make you healthy. So if the number you got is a little bit more than what you hoped for, if it helps you to become a healthier person, then I feel like we've accomplished our mission. So again, my final slide, the keys to success. Remember that your surgery is just a tool to help you get to where you couldn't otherwise get on your own. It's sort of leveling the playing field. But you are expected to maintain a good, healthy diet. And that diet is usually described as a Mediterranean-style diet. Lots of fruits and vegetables and protein, plenty of protein. We want you to stay away from the junk food. And then finally, we want you to get some exercise in and stay connected with us. It's so much easier to stay connected and have us address a small problem and get it easily fixed than to not hear from you for a year or 2 or 3 or 5, and then all of a sudden you're calling the office with a terrible problem that, had we only been in touch on a regular basis, could have fixed easily, and now we've got a big problem that maybe needs some kind of revision surgery or some other major steps that could easily be avoided. So we want to see you back after your surgery, 1 week after surgery, 1 month, 3 months, 6 months, 1 year, every 6 months thereafter. Besides that, we have all of our social programs. We have our picnic in the fall. We have our Christmas party in the wintertime. We have our annual cruise. We usually do a Caribbean cruise, as well as other social events throughout the year. So we have lots of ways for you to stay in touch with us, as well as my phone number, which you'll have access to anytime, emails, text messaging. There's no reason for you not to be able to stay in touch with us to let us know what's going on in your life. Again, I'm thrilled that you've made this choice to change your life through MGB surgery, and I look forward to seeing you very soon.